In this lecture, we will discuss how to use the EKG to localize the ischemic region in ST elevation myocardial infarction. Up to this point, you should have a good grasp of the EKG progression during myocardial ischemia, along with what constitutes true ischemic changes. We now want to not only recognize these ischemic changes, specifically ST elevation, but also localize these changes on the EKG to specific regions of the heart and the potential artery involved. Let's review the relationship of the leads to the heart regions, as well as what ST elevation in certain leads may suggest. First off, take a look at the picture we have on the right. It's the coronary arteries, a picture of the heart, as well as the leads. I think this is a beautiful picture and one you should probably make copies of to have on hand. This really helped me when I first started to learn how to interpret EKGs. It gave you a good reference of where the leads were, where the arteries were, as well as in relation to the anatomy of the heart. So let's take a look at this, okay? So I'll walk you through this, okay? And I'm talking about these leads. So notice we have our frontal leads. Here's 3, here's AVF, 2, AVR. This is negative AVR, okay? Remember AVR would be in this case, okay, up here. So that's negative AVR. Here's lead 1 and lead AVL, okay? Then you can also see all the precordial leads placed here. Here's V1, and as you continue all the way to the left side, 2, V3, V4, V5, and V6, okay? And we've also added here V7 through V9, which are our posterior leads, so they're coming around the back of the heart, okay? Going to the right side, we have our right-sided precordial leads, where V3R all the way up to V6R, okay? So we have both the horizontal and frontal plane present here. Now let's take a look at our anatomy, okay? So our right ventricle would be in this portion here. We'd have our pretty much left ventricle sitting in this area here, okay? Remember, the right ventricle is the most anterior portion of the heart, okay? And then we would have our right atrium here and our left atrium here more posteriorly. In terms of the anatomy of the coronary arteries, we have our aorta, okay? Gives rise to our right coronary artery, as well as our left main coronary artery. Okay, in the dominant right coronary artery or right dominant system, the right coronary artery supplies the PDA. Okay, remember the PDA, and supplies the inferior portion of that left ventricle and that posterior 1/3 of the interventricular septum. The left main coronary artery gives rise to the left anterior descending artery, the LAD, and the left circumflex artery. Okay, so that's all that we have going on here. You can also see a bunch of the small other arteries involved, but I want to erase this so we can kind of line this up to see what we need to know. Okay, so again, I'll also put AVR here. Remember, this is negative AVR. Okay, now if you look over on this side, we have the standard 12 lead EKG, okay, and I put that there as a reference, okay, so the lateral leads 1 and AVL, okay, and you can also consider V5 and V6, which are sometimes apical leads referred to as. So imagine here's 1, here's AVL, here's V6, and here's V5, okay, so those leads, and they're all here in blue, so you can know that they're on the lateral portion of the heart, okay. And the inferior leads sit on the inferior portion of our heart. So again, here's lead 2, here's lead 3, and AVF. Where are they? Here's 3, AVF, and 2, okay? Seeing the inferior portion of our hearts, okay? So if we are looking for ST elevation or an inferior infarct, we're going to look at those leads. So we'll look in these leads here for any ST elevation. The septal leads are V1 and V2, okay? Here's V1 and V2, as well as then we have the anterior leads sitting over the anterior portion of the heart, V3 and V4, okay? Sometimes you'll hear V2 through V4, including the anterior leads, or even up to V5, okay? But this is a good way to space them out. Septal leads, V1 and V2, okay, V3 and V4 are the anterior, and V5 and V6 the lateral or apical leads, okay? So let's see now, and one thing to know is notice AVR, it's black here, we don't really use it, okay? Sometimes there is some significance to it, but we won't get into that detail in this lecture, okay? So now in V1 and V2, so we're going to look at ST elevation, the ischemic region, and the artery that's occluded. Okay, so what we're going to see here, if we see ST elevation in V1 and V2, which are these leads, it's hitting over the septal portion of the heart, okay? And often it's the proximal LAD that's occluded. Okay, here's our LAD, it'd be up here. Our septals aren't getting any blood to them, and that's where we tend to see them, okay? Now there's also V3 and V4, okay? Also the LAD supplies, so that's V3 and V4, which are these leads. Let's just erase all this here. So we talked about V1 and V2, now V3 and V4, again, sitting over the anterior portion of the heart, the LAD that supplies it. So you can have that area that's cut off from that, okay? So you look here, V1, V2, V3, and V4, that would be like an anteroseptal MI, okay, if you have both of those regions involved. If you have V5 and V6, which are the lateral or apical, okay, so V5 and V6 here, that could be from the distal LAD, okay? So imagine a distal artery off the LAD, so here's our distal LAD, somewhere there is occluded. You can maybe see changes there in that apical region. The left circumflex, which is this one here, or the right coronary artery, okay, as it comes around. Now in terms of 1 and AVL, so lead 1 is here, lead AVL, and then in reference to our, let's just erase some of this. So again, so 1 is here, and AVL, sometimes referred to as our high lateral leads, okay? So we'll see a lateral infarct, okay? That lateral region of our heart is being affected, which is our left circumflex that is feeding those areas, okay? Now in these cases, you'll see ST elevation in 1 and AVL, and then you'll see reciprocal changes, reciprocal ST depression, okay? Because they're the opposite changes in the inferior leads, okay? So imagine this region here, the opposite would be these inferior leads, okay? Even more so in lead 3, where you may see even greater ST depression, okay? So you'll see ST elevation in these leads, ST depression in our inferior leads, okay? Now in terms of an inferior MI, you're pretty much seeing the opposite changes, okay? In the inferior leads, you'll see ST elevation, and then in leads 1 and AVL, now you'll see reciprocal ST depression, okay? Now, oftentimes the artery that's involved is the right coronary artery much more than the left circumflex artery, because remember, right dominant is present in about 85 to 90% of people, okay? And that's why we tend to see that. In terms of our posterior leads, V7 through V9, okay? So again, let's just clear this up from the mess I made here. So V7 through V9, which is this area here, are posterior leads, okay? So if we see ST elevation in those leads, we'll see ST depression in leads V1 through V3, okay? And if you recall, one of our pitfalls with a standard 12-lead EKG is with these leads, maybe you'll see ST depression, but no evidence of an ST elevation MI. And that's because you may actually have a posterior infarct. So you want to put the posterior leads, and if you put them there, you may see ST elevation, okay? And this is a posterior infarct, or you may also hear it referred to as a posterolateral infarct or infrabasal, all meaning the same thing. And this can be either from a right coronary artery obstruction or left circumflex obstruction. Okay, so hopefully this is all making sense. What we're doing now is combining the leads, combining the heart anatomy as well as the coronary anatomy, and now putting it on the EKG to see what is actually going on. Okay, so I think you'll come back and you'll reference this quite a bit, because this is really what helped me a lot, and you really want to just keep going over it, and soon it'll become second nature. Now in upcoming lectures, all of this information along with our coronary artery anatomy will prove to be very important as we look at the EKG findings that appear with specific coronary artery obstruction, or even the specific location within the coronary artery that is obstructed. Well, that's the end of this lecture. We discussed how to use the EKG to localize the ischemic region in ST elevation myocardial infarction. I hope you learned something.